Hello everyone, and welcome to another high-yield USMLE question. This is a 55th question in the medicalized question bank. So we have a 30-year-old female presented to the office due to blurred vision. The patient has no other complaint except for fatigue. Medical history include fibroadenoma diagnosed 4 months ago and polycystic ovarian disease. Vitally, the patient is stable. General physical examination is unremarkable except for hirsutism. Probably that is because of the PCOS. Eye examination shows failure of the left eye to adduct, which means move medially, when the patient is asked to look to the right and there was concomitant nystagmus of the right eye. Now, the patient is asked to look towards the left. Now, the patient is asked to look towards the right. The left eye did not adduct and the right eye had an nystagmus. So which of the following is the area of this patient's lesion? So remember, the thing that they are describing here is something called internuclear ophthalmoplegia, and it is medial longitudinal fasciculus lesion. C is the right answer. So usually it is seen in someone who has multiple sclerosis. Usually it's common in females. Other risk factors include vitamin D deficiency, someone who lives in cold climates. These are some of the risk factors for MS. Now here, internuclear ophthalmoplegia, we are gonna discuss in a bit more detail. So key points in the question are eye examination. So internuclear ophthalmoplegia is the answer here. And it is seen mostly in multiple sclerosis. Typically, it's bilateral, and that is high yield to know. Like we have to know in the question if it is left INO or right INO. It's a bit confusing, and we will discuss it in a bit. Like how to know if it is right INO or a right MLF lesion or left MLF lesion. So failure of the adduction in the affected eye, high yield to know. For example, if here they said that the left eye failed to adduct, this is the side with the lesion. Left MLF has a lesion. We will discuss this in a bit more detail in a bit. And the normal eye then has nystagmus. So if they say, what would the normal eye do when you tell the patient to look from the normal side? For example, here, left eye failed to adduct, which means that the left eye is the problem. The left MLF has the lesion. The patient is asked to look towards the right, and now the patient's the normal eye, which is the right eye, has nystagmus. The right eye will have a nystagmus. A, cerebellum, wrong answer. Usually they will give you other features of cerebellar dysfunction. They can give you nystagmus here, but nystagmus is very specific. It only occurs when you tell the patient to look to the right. Also, cerebellum has other features, like they can have ataxia, for example, or dysiridokinesia. So, but the cerebellum here, wrong answer. Optic nerve is the wrong answer. Here, they will have the pupillary reflexes are usually affected, so they can have that. For example, if you have something called optic neuritis, which can occur in MS, but they will also cause blurred vision, but it wouldn't cause this internuclear ophthalmoplegia, this eye examination finding. It won't cause nystagmus. It won't cause failure of adduction. So wrong answer. MLF is the right answer. Cranial 3 lesion is the wrong answer because it can cause, for example, it can cause the down and out pupil if it is damaged. And then it can be dilated, or the pupil can be dilated or not dilated, depending if it is pupillary sparing or pupillary non-sparing lesion. Then cranial 6 will be failure to AB duct. So it's a lateral rectus palsy. Cranial 6 lesion will cause lateral rectus palsy. You will not be able to look towards the laterally. You will not be able to AB duct, not adduct, AB duct the affected eye. So wrong answer, E. Right answer is medial longitudinal fasciculus. Now we are going to discuss the medial longitudinal fasciculus, the eye internuclear ophthalmoplegia, in a bit more detail on this image. So now what happened here is that let's imagine that we have the two eyes here. L represents the left eye, R represents the right eye, and the two red areas on the side of the eyes represent the lateral rectus and the medial rectus. The one on the medial side is obviously the medial rectus. This one here is the medial rectus, and this is the lateral rectus. Now, Now, let's say these two dots here are cranial nerve 6. They represent the cranial nerve 6. Now, we already know what the cranial nerve 6 supplies. It's the lateral rectus that it supplies. So here it will supply the lateral rectus and cause the eye to look. It will cause the eye to abduct. Now, how you'll to know is that the cranial nerve 6 receives signals from PPRF to kind of do the conjugate eye movements, which we'll discuss in a minute. So, and then we have these two hexagons here. They just represent the cranial nerve 3. They represent the cranial nerve 3, and they will supply the medial rectus. Remember, the medial rectus is supplied by the cranial nerve 3. And then the medial longitudinal fasciculus kind of links the cranial nerve 6 also to the cranial nerve 3. Now, why is this important? This is important because, let's say if I ask this patient, let's say this is a normally functioning pathway. MLF is functioning. All the pathways are functional. This is a normal human's brain. Now, if I tell this patient to look towards the right, let's say, if I tell the patient to look towards the right, what is going to happen? The cranial nerve 6 will be stimulated by the PPRF. This is stimulated and this is also stimulated. Now, once they are stimulated, obviously they will go to the lateral rectus here, and the lateral rectus is going to cause the eye to go towards the look towards the right side laterally. At the same time, what we need here is stimulation of this medial rectus of the left eye. We need this as well. Now, what's going to happen here is that through the medial longitudinal fasciculus, the cranial nerve 6 that was stimulated is going to stimulate the cranial nerve 3 as well, and this cranial nerve 3 is going to stimulate the medial rectus of the left eye. So this way, this eye is going to move here, look towards the right, and through the lateral rectus, the right eye is going to move here and look towards the right side. This is normal. Now, let's discuss what happens when you have something called the lesions. Let's say we have now the lesion here. So if you have the lesion here, which is in the cranial nerve 3, which is in the medial longitudinal fasciculus, now let's discuss what's going to happen now. So remember, this is left MLF lesion. It's on the left side, so we are going to say that this is left INO. Left INO is going to occur. Now let's repeat the same steps that we discussed for the normal eye. Now PPRF is going to come here, stimulate this cranial nerve. We are looking, let's imagine we want to look towards the right. Now it's going to come here, stimulate the cranial nerve 6. Once it is stimulated, it's going to stimulate this lateral rectus, and this eye is going to go to look towards the right side. At the same time, it wants to stimulate the cranial nerve 3, but here it cannot because there is a lesion. So what's going to happen here? This eye, the left eye, is not going to adduct. This is the eye with the lesion, adduction failure. So this eye did not adduct. Now, this eye will go will abduct. It's going to look laterally, but then it's going to get confused because this eye did not follow it. So what's going to happen? Nystagmus. So nystagmus in the right eye, which is the normal eye here, and the side with the lesion, the left eye, will not be adducting. So that is your internuclear ophthalmoplegia, left side. Now let's imagine that we want to look actually to the left in this patient with left MLF lesion. It's going to be completely fine because you're stimulating this. It's going to stimulate this lateral rectus of the left eye. Also, it's going to go and stimulate the cranial nerve 3, and it's going to stimulate the medial rectus of the right eye. And this patient is going to normally look towards the left. So looking to the left is easy, is normal. Looking to the right is not normal in patients with left MLF lesion. Now, to further clarify this point, internuclear ophthalmoplegia, this is the eyes. They represent the eyes here. This is the baseline. They're just looking medially here. And then let's say you want to look towards the left, and we look towards the left here. It's normal. We can look towards the left. And let's say we have left MLF lesion. And when we tell the patient to look towards the right, what's going to happen is that this eye, which is the normal, the right eye, is going to it's going to abduct. It's going to go laterally, but it's gonna have nystagmus. This is the normal side. It's gonna have nystagmus, while the left eye will fail to adduct. This is the left MLF lesion, and it's gonna stay in the midline. So high yield intranuclear ophthalmoplegia to know for the boards. So hope you enjoyed this video. If anyone requires tutoring, they can email me at medicalized@gmail.com. Also, you can get my Step 2 CK high yield notes. Link will be in the description. Thank you for watching.